Good morning, everyone. We are expecting more delegates to join, but we'll get started. So today's event is around owning outcomes to support the delivery of quality services. So my name is Kamini Gadhok and I'm Chief Executive at the Royal College of Speech and Language Therapists. Absolutely wonderful to see how many people have registered for the event. And we've come a long way since the launch of this work back in 2013, for those of you who were around then and remember it, where we were very concerned that we were hearing that services were going to be funded based on the outcomes that they delivered, and we thought we ought to do what we could to try and support our members to ensure that they could show the outcomes that they were delivering on behalf of their service users. So we've come a long way since that time. And it's great that we've been able to keep up the momentum, including over what's been a very challenging couple of years. So thank you to Catherine, because she's put this map together. I said to her, it'd be really nice visually just to see where delegates are from. So you can see they're from all over the UK. And we've also got a couple of members who are going to be joining us from overseas today, which is fantastic. So today's event provides an opportunity to celebrate the progress our profession has made to date, and also to continue our learning through hearing from a number of really excellent speakers that we have lined up. So whether you're absolutely completely new to outcome measures or have years of experience, we hope that you'll be able to take something away from this event. We recognise that many of you are making strides of progress towards implementing and using outcome measures to shape service delivery before the pandemic struck, and that many of you have had to put some of that work on hold to make way for other priorities. So we're hoping that today will inspire you to revisit and continue with where you've left off. As you know, and we know, gathering outcomes data has never been more important, and we keep being reminded of that. So I do hope that you take a lot from the day. But before we start, I just want to give you a bit of housekeeping tips. So first of all, your virtual delegate badge, I think I've mentioned, put your name on as it will be displayed on Zoom. So you can click the 3 dots on the top right-hand corner of the window with your video, just to do that if you haven't done that as yet. Do use the chat function to introduce yourself to others or to ask questions and to network. If you need to leave the event or you drop out the event at any point, please do rejoin on the same link. But when we come to the break, I think it's easier that you just turn off your camera and then, leave yourself in the link, just so that it's easier to come back in after the break. In terms of additional needs, if you have any additional needs, please feel free to send a private chat to Rebecca, the RCSLT host, and Jazz is also on the call, and both of them will do their best to help you. So in terms of recording, we are recording the first hour of the presentation. We haven't sought permission to record the parallel sessions, but if we're able to do that, we will do that as we go through the event. In terms of cameras, you're very welcome to keep your camera on or off. It's entirely up to you. And please do, though, put your microphones on mute. I know I've been hosting events recently where people haven't realised they've got their microphone on, and we get a lot of background noise. So please do that if you're not actually speaking. In terms of the delegate pack, you'll have had an email with all the information about how to download it for today, and Sammy's going to put a link in the chat box, so you've got that again. The pack contains the programme and information about the speakers and links to the presentations, which you can also download, and a form for you to use to capture your own reflections throughout the morning, because it's really important that wherever you are in the journey, that this is part of supporting you for your next step. Just wanted to introduce that we have a virtual scribe, who's Amber Anderson, and she's going to make a visual recording of the opening session this morning, and will be captured live. And if we have a chance before we get into the break, we'll ask her to share that with all of us, so that will be lovely. Please do use Twitter if you want to share any information that you're learning on the #RCSLT outcomes, as you can see on the screen. And before I forget as well, evaluation is really important, that we, at the end of the day, we will be giving you a link to an evaluation form to get your feedback. So please do complete that to help us learn from how it went. So I'm just going to move on to the aims and objectives. So these were provided in the programme for today, and I'm not going to go through all of them, but here they are on the slide. And you also had some pre-event materials, and we're really thrilled that we had video contributions from each of the 4 chief allied health professions officers from across the UK, and here they are, as well as the Chair of the Board of Trustees, Mary Heritage, who I think is also joining us, and they can all be viewed via the RCSLT YouTube channel. A special welcome also to members of the Outcomes Steering Group. So thank you so much to colleagues on the steering group who've been involved in helping to plan this event, and those colleagues who are attending today from the steering group include Vicky Stiles, Charlie Harris and Amelia Austin. So thank you so much to everybody for all their hard work to get us to this point. Now, before for the next, I'm just going to introduce the next, or the first speaker actually. How can I not do this really well? And it's Professor Pam Enderby, who's Emeritus Professor at the University of Sheffield. And she's going to be presenting on what do we mean by outcome measures and why is measuring outcomes important? So over to you, Pam.
Thank you so much for inviting me to come and present to you today on a subject that has been very close to my heart for more years than I'm going to tell you. I started being interested in outcome measurement because I was very concerned that so many people many years ago and still now say, does speech and language therapy do any good? And yes, we have a great deal of research that can help us, but actually an awful lot of the individuals we see, it's very hard to have the evidence that we are benefiting them. So what is an outcome? An outcome is the effect we have. And it's not to do with the process, it's what is the impact that we are having with people. Next slide, please. And it's important to know patient outcomes because we need to be able to communicate to other people that it's not just, speech and language therapy is not just getting people to speak. It's also helping them to communicate, of course, or to feed and swallow. And we might be thinking we're doing that, but actually the biggest impact we might be having is actually improving the feelings of the patient, the emotions, the well-being, by teaching them to understand and to manage their problem. So you might have been aiming to do something, but having a completely different impact. We may have a big impact on the carer or the relative. And that might have not been our intention to begin with, but that might be the biggest effect that we're having. It's part of the quality cycle. It's so important to be thinking of, can we do more? And what are our strengths and weaknesses? Next slide, please. Why has outcome measurement become so much of a buzzword now? Well, we all know that there are increasing demands on the health service, and that will go on because the demography of the country is changing. The proportions of older people, people living to over 80, is increasing. The numbers of young children surviving with quite challenging problems is increasing. Those are all great things, but it means that we really need to have more rehabilitation enablement within the health service, and the health service at large is the demands on it are becoming greater. So the stresses on finances is greater. Now you may know that one 40-minute session of a grade 6 speech and language therapists costs the public purse £70. That's a lot of money. When you think of the thousands of people requiring not only speech and language therapy, but physiotherapy, occupational therapy, and everything else, we have a responsibility in thinking, is that £70 really worth £70? It's stopping somebody else having something else from the health service. It might be stopping some expenditure on a walking aid or on incontinence pads. And so everything that is going into the health service and not being effective is stopping something else that might be effective. But there's another reason why it's come to the top of the agenda. There is great variation in provision. You and I know that. You can get some things one side of a boundary and not on another side of a boundary. But do we really know the variation in the provision of speech and language therapy. The fact that some places you don't get referred to speech and language therapy until really a severe problem, whereas others you might have access when it's milder. And even within one region that can vary. It can vary because of many different things. For example, it might vary because there isn't a good bus service and some people cannot get to the area of provision. So we really need to demonstrate the benefits of investment, but we also need to think of what are we really doing in our service, and what am I doing as a clinician? Next slide, please. You will have heard so many politicians saying we've really got to change the health service. We're going to come out with a new framework. In England, we've got the integrated care systems, the integrated care boards. In Scotland, Wales and Ireland, there are changes, but not using that phrases. But when you boil down all the changes, they boil down to 4 big emphases for the next period. Really what the NHS wants to focus on in the next period. Firstly, improving outcomes in population health, not just only focusing on individuals, but overall. How can we do that? We can do it by tackling inequalities and making sure that your outcome is not related to actually what your immediate problem is. It is taking into account a broader area of issues. The NHS is very keen to look at how we can enhance productivity and value for money because of the demands on the finances. And I think we should take that responsibly as well. Nobody owes us a living. We owe the general public good work for our pay and for our profession. We help the NHS, we need to help the NHS support a broader social and economic development. Well, speech and language therapy should be at the heart of that, because if we can help children with special needs to become better educated, have better literacy, be able to socially engage, it's more likely that they will get employment. It is more likely that they will not need further health care of such a broad nature in the future. It's more likely that they will not get in touch with the justice system. So we can really be at the heart of all those 4 areas. We can enhance productivity by being sure that we're doing a good job. We can tackle inequalities because we can make sure that people who need our help get our help from wherever they are. And we can improve the outcomes in population health if we know what we're doing. And next slide, please. So the ICS, which is the integrated care systems that are coming into place in England, their focus sort of reflects some of this prevention. And we can do a lot for prevention, but can we demonstrate that we do it to the people who fund us? Can we demonstrate that these care pathways that are being set up in every area can be personalised and therefore more effective for each individual patient? Can we demonstrate that the performance is actually meeting the needs of that population? And the next slide, please. So how do we know what we do? How can we tell other people what we do? It's not in the number of people who still think that speech and language therapy is about talking, is about only working with children. It's a great deal. And some of those are in influential positions on boards that actually look at the finances. We have to be able to explain, yes, we do something about the disorder. Yes, we can help people communicate. Yes, we can actually help people engage more socially. And we do a lot for well-being. But each service can also do more, and each year we should have the ambition of doing more in all of those 4 areas. Can we, next slide, please. So we need to know what we're doing now. Otherwise, we won't produce the outcomes we expect. We won't serve populations equitably because we're not aware that we are serving them inequitably. We could be overused, but we could be underused and not having referrals that we should be getting as compared to perhaps just across the border. We may not be connecting with other services, some of whom could do a better job with some clients than we do, or working with them, we can be more effective. And we won't be able to be advocates for our clients. Speech and language therapists in particular need to be advocates for their clients because of the nature of their difficulties. Next slide, please. We know that we have a lot of research now underpinning speech and language therapy, but it still doesn't serve us well, in that most research, and I would like much more research, I'm not against research, as you can hear, but it's important that we realise that most research in speech and language therapy is on people who have one disorder, and yet the majority of clients we see have more than one disorder. They have multimorbidity. But in addition, the research we do necessarily has quite small populations. We really need to put that research into the context of what we do every day with multimorbidity, with everybody. And does what happens in research, is it possible to generalize it? Or is the nature of the way that we set up our services makes it impossible to give the amount of dosage, the amount of times we see patients? In research, maybe 4, 5, 6 times a week. Can we do that in reality? So we need the context in which to do our research. And this is really being helped by gathering data on thousands of people so that we can think, are we actually doing what the research is telling us? Yesterday, the National Institute of Clinical Effectiveness, NICE, did a webinar which I attended on real world data, big data, gathering a lot more information in a consistent way. And they're saying, and it was music to my ears, we need this to actually help us to interpret randomized controlled trials and other trials with supportive methodology. If we can actually see what's happening, we can actually convert those research products into something that's more meaningful. And the next slide, please. But it's not just about collecting data and collecting data in a consistent way. And the next slide, we really need to use that data. We need to be able to communicate that data to our clients so that they know more about our intentions and what we're doing with them. Our team members, so that they know about the objectives of our service and whether they're meeting them, with our colleagues from other healthcare professions, from referrers. Do the referrers really know the impact that we have on the people they refer? Obviously, service managers need to help, but particularly service funders. And so often I hear people say, well, they never ask us. Don't wait to be asked. Tell them what we're doing. Give them information, basic information on what our services are providing. We may wish to, and I think we should, share that with the third sector working in our patches so that we can work more closely together. And of course, it goes without saying that we have to advocate for our clients with commissioners and of course support the profession in having an impact with the politicians so that we get represented appropriately at the highest of levels. And the next slide, please. Well, you can see that I'm edging into the territory of the therapy outcome measure. But today is not just about the therapy outcome measure. There is no outcome measure that really is sensitive enough and reflects the complexity. But we do need to have an outcome measure that reflects what we do with the disorder itself. And there will be clients where we can't do much with the disorder itself. So do we do anything with improving function, either swallowing or in communicating? Do we do anything on psychosocial gain, the social aspects, improving friendships, improving confidence, etc. And of course, well-being. And the next slide, please. So the overall objective speech and language therapists might be to improve a disorder, but there are many people we see where we can't improve any of those aspects, but we might be wanting to maintain them because they may slip back if they aren't seeing us on occasions. And of course, we see people that are in palliative care or got a deteriorating condition, neurological condition, and we help to manage decline. Now, even that, can we split our caseload? How many do we actually want to see improvement? How many should we see that we're maintaining? How many do we help with their end-of-life care? Even something as basic as that, we should have a handle on. And obviously there are some people that we aim to maintain and they improve. That's absolutely great. Some people we maintain and they decline. What are the percentages of that and why would that be the case? So it's a fairly general thing. And it's rather sad that we don't have the response of what services are doing what are the proportions of clients? Are we not getting enough palliative care clients referred, that another area is seeing more of them? Are we getting some people referred for maintenance, but not as many as another service? Those are things that we need to look at when we're looking at the quality of service provision. And the next slide, please. Well, there are lots of things that are called outcome measurement, and some are outcome measurement and some aren't. So patient-reported outcome measures are obviously very important, and very often we will be doing this as we go along, finding out what the patient thinks that they're benefiting from, how are they, do they feel they're improving. These references here, which will be available for you, show the strengths and weaknesses of patient-reported outcome measures. A lot of people think I'm against them. I'm not against patient-reported outcome measures. They are desperately important to each of us. However, relying on them is problematic because, of course, patient-reported outcome measures means that it is very much to do with the character and the personality of the patient. There are some people that even when you and I think that they've had a great outcome, will feel as miserable as sin because there's their personality. You know, life has dealt them a difficult hand, or their personality is such that they're going to be flipping miserable whatever we do. And there are others who will downplay their problems so much. So the personality comes into patient-reported outcome measures a lot. Doesn't mean we ignore it, and it's very important as a therapist to know their approach, their attitude to their improvement, recovery, or maintenance. There's another area which is called patient-reported experience measures. This is not an outcome measure, but desperately important to know from patients. What was your experience with the therapist? And very frequently, if we actually ask them that in writing or verbally, they might bring up something that's really interesting and important to us. For example, they might say, well, the therapist told me to do some exercises, but by the time I got to the car, I'd forgotten what she'd told me. So you can be prompted with, maybe we ought to think of how we can help people to remember their exercises. Or it might be something very different, but quite practical, that the person's experience was good, but it was very hard to get to the clinic because the signage wasn't so good. Or things like that, very practical things we can learn from a patient's experience measure. And then we come on to the TOMS. Shall we go on to the next slide? Well, choosing any outcome measure, whether it is TOMS or another one, there are many out there. It's got to be relevant. So it's got to cover all those four areas: the disorder, the functioning, the independence level, the psychosocial, and the well-being. It's got to be valid and it's got to be reliable, i.e. reliable is that it's, if there are two therapists seeing the patient at a very similar time, that they'll come out with a similar result. But the two things that in 2013 and before that RCSLT felt were very important is that it must be easy to use. It mustn't take a 40-minute session to do an outcome measure. It's got to reflect the clinical opinion, and it's got to be easy, help us to communicate with others what we're doing. So let's go on to the next slide. Even looking at data on things like discharge codes are important, and these are the 7 that are often used within the, it's 8. These are the 8 that are often used within the NHS. I'm just going to tell you a very quick story. I've just got a few minutes so I can. That there was one service that noticed that there were suddenly an increase in did not attends at the Child Development Centre. Now, they wouldn't have noticed if they hadn't looked at, month after month, what are the reasons for discharging patients. They noticed suddenly an increase in did not attends. They thought, is there a new member of staff that's particularly grumpy and putting people off? No. But it turned out that it was the bus service. The bus service from a socially deprived area of the city had suddenly changed. So instead of being one bus from that area to the area where the Child Development Centre, you now needed 2 buses. You had to go into the bus terminus to get another bus. That took longer and cost more. From a socially deprived area to the Child Development Centre, just the children we need to see. Just having that information, it was possible to go to the local authority and say, look what's happened. This is not helping public health, etc. And the bus service was changed back. Now, that was the speech and language therapists advocating for their clients. No mum would have done that on their own. They wouldn't have noticed that a lot of other people were having difficulty. So we do need to look at even the basic data as part of our quality cycle. And the next one. Reliability, sensitivity and clinical significance. I will cover over fairly quickly. I've just had the prompt of speed up Enderby. Okay, thanks, Catherine. Reliability is consistency. Consistency in results, terribly important. If we are going to have big data, it's got to be good data, solid data, data that we can depend on. Sensitivity to change is a challenge to every single outcome measure in the world. The further away you are from something, the bigger the difference has to be able to spot it. Dead and alive, I think we could all discriminate between those two. Dead, half dead and alive becomes more difficult to discriminate. And the more points on the scale, the more difficult it is to be reliable. So you have to spend a lot of time looking at how sensitive can you be, but maintain reliability. And that's why the TOMS took around about 20 years to get to an 11-point scale. But it's never going to be as sensitive as what you see with the client, with your therapist eye. It will never show those tiny changes that are important to you as a therapist, important to the client. And it's frustrating for therapists because they think, oh yes, we're doing more than the TOMS shows or this FAM shows or another measure shows. It's bound to be the case, but at least we are reliable and consistent. Clinically significant is when it's actually a change, determined as a change, because it is significant to the patient and to the clinician. So you might see changes, but it actually is not making any difference to a person's life. So again, it's something that we need to consider, is we want to spot changes, but that are significant to somebody's life, that actually has made a real life difference. And the next slide. So I do actually get onto the therapy outcome measure in the end. You can't really stop me, can you? It's a cross-disciplinary method of gathering information on a broad spectrum of issues that require therapy, enablement, rehabilitation. But it's based on the World Health Organization's international classification of functioning. And that's useful because the ICF is well known by a broad range of health and social care staff. And you will see the main characteristics there. The one that we added that is not in the ICF is well-being. And we actually looked at the goals of therapists And the goals could fall down into the end area of trying to change impairment, trying to improve activity independence, trying to improve social participation. But there were goals on well-being of the client and well-being of the patient that weren't covered, so we added that. It's an 11-point scale, it's got half points, and it's administered at the beginning and end of an episode of care. And the next slide, please. So, do you know what you're doing? Obviously, the mum had been told it's a good idea when you put a baby in a car to put on a seatbelt. And it was done with good intention. And one was trying, presumably this mum was really trying to abide and keep her child safe. Sometimes we can intend to do something that can look as bad as this. And so we need to be critical and ask ourselves, do we really know what we're doing with every patient? Do we know our strengths? Do we know our weaknesses? And each of us will have strengths and weaknesses. Some of us will be really good at the theoretical underpinning of the disorder itself and understanding what needs to be done for the impairment. But we may not be so good at the supportive aspect, the psychosocial aspect. There will be others that are excellent at engaging with patients, really helping them to understand their problem. But they may not be so up to date with the best techniques to improve the fluency disorder or the voice disorder. We need to keep an eye on ourselves all through our professional lives. So thank you very much indeed. And I pass you back to Kamini.
Thank you so much, Pam. Lots of food for thought here and really important points that you've made, which I'm sure everybody will reflect on. So Katie and I are going to just move on and actually, I think, really develop on some of the themes that you've raised there, Pam, I hope. So to the next slide, please. Thank you. So Katie and I are just going to go through these key areas. So just remembering what we're here for, who we're supporting, how we support them, and how do you know if it's working, and also who needs to know. So next slide, please. What are we all here for? Well, I think if we go to the next slide, I think it's something that we all came into the profession for, which is to create better lives for all people with communication and swallowing needs. And those outcomes, as Pam said, that are those that matter to individuals in the context of their own lives, understanding their individual needs in terms of their home environment, their role within the life that they lead, whether that's within the family or the community or the world of work, and taking account of language, culture and religion as part of that, as well as broader friendships, as well as families I've mentioned. So it's really important that services are able to meet the needs of our diverse populations. Next slide. And obviously, who are you actually supporting? So if you go on to the next slide, going on to data again, Pam was talking, I think, really well about interesting issues around socioeconomic status and thinking about things like access to local transport, car ownership. So can people actually get to you? But before you even start that, do you really know who your local community is? Do you have the data? It is available to understand the population. Do you have the information you need about the size of the population? And things like, for example, how many children are actually being born in your area? I'm going to come back to the population characteristics, so as well as the socioeconomic status, issues around religion and ethnicity, and thinking about what are their likely needs going to be in terms of incidence and prevalence. So how many members of your population may well have a stroke? How many should you therefore see within your caseloads? It's really important also to look at individual service users' context, preferences and needs once you have that data and that information. If we move on to the next slide, I'm going to pass over to Katie. Thank you.
Thanks, Kamini. So if we go on to the next slide, I'm just going to talk a little bit around the, this question of, well, how do you support them? So carrying on from where Kamini's left off, so once we kind of have understood our local community and our individual service users, we need to think of how is the best way to support them, really. And this is where evidence-based practice comes in. So how do you understand what works? Well, really, we should be advocating for this approach for evidence-based practice, which sort of triangulates different sources of information. So we've talked about the external scientific evidence, and Pam has referred to some of the kind of limitations around that, which I'm going to link back to in a moment, but also importantly kind of incorporating your clinical expertise and experience, and of course the service users and caregivers' perspectives and preferences. So if we go on to the next slide, I'm not going to talk much more about kind of the theoretical background of evidence-based practice, just to note that the RCSLT does have quite a lot of resources to support you on that. But I did want to, so if we go to the next slide, touch on a point that Pam has made really nicely earlier. And actually, when we're thinking around scientific evidence as part of evidence-based practice, where does outcome measures actually sit in that? And we know that, as Pam has already said, that evidence can be kind of complemented by what we're calling, real world evidence. Outcome measures is a really key part of that. So especially in areas, for example, where we don't have much evidence or where they're new. So COVID has been a really good example of where real world evidence has really come to serve our evidence base and our knowledge base. And outcome measures can be brought together with all this other kind of information to inform on the best ways to support our service users. So Kamini's already alluded to looking at things like population data, incidence and prevalence, but also things specifically about our individual patients, so their kind of characteristics, the kind of outputs or clinical data that we might think of, so test and assessment scores, or things like the number of therapy sessions we're giving, as well as other bits of data, so possibly things like inputs, staffing numbers, productivity data, and also things like cost effectiveness or return on investment. So all of this kind of information can really be used to help us decide what's the best way to support our service users. If we could just go on to the next slide. As part of this, I just wanted to highlight as well that the RCSLT has got some case studies that sort of exemplify different ways that our members and therapists have used sort of different types of real world data to inform on their practice and develop their services and improve quality, should you be interested in checking those out. I think I'm now going to pass back to Kamini briefly. If we can go on to the next slide, please.
Thanks very much, Katie. So apologies that we're getting through this very quickly, but really important that we look at joining up all of the data that Katie's mentioned. So triangulating everything you know about the local community, as we said, the different types of evidence and data that you've gathered, your own clinical expertise and experience, and then very importantly, that co-production piece, which is agreeing with the individual service users, families and others who may be involved on the outcomes that matter to them and what are the things that they are looking for. And as part of that, considering their culture, their value systems and beliefs, and how they actually shape the purpose of the intervention that you're going to deliver. And that will help you to co-produce a care pathway which delivers and supports achievement of meaningful outcomes. So very much going back to some of the things that Pam raised earlier around being person-centered, being holistic and joining up with others who might be involved in delivering that care pathway. So next slide, please. So I think it's really important then to go on to how do you know if it's actually working. So I'm going to pass back to Katie to talk about this important tool.
Thanks, Kamini. So yeah, so I suppose going off then from where Kamini's been looking at the point at where you've done the doing, you've implemented something, and what's really important, again, as Pam has been highlighting this morning, is how do you understand if it's working? How do you know if it's working? Is your service effective? Is your service actually up to the job of serving different communities or populations and diverse communities? So evaluation and monitoring is really crucial to this, and outcome measures is a really key part of that, but it can also be complemented by other types of information. So what I wanted to highlight here was the health inequality self-audit tool that the RCSLT created last year alongside with members. And this is a tool that individual therapists or whole services or teams can use to actually evaluate, am I doing what I need to be doing to ensure the needs of my local population, can be met by the service. And this is part of a evaluation. So this can be used alongside things like outcome measures and some of that other information that we've talked about to really identify, is our service working? Are we achieving the therapy outcomes we hoped? If not, why not? And that is where the self-audit tool can really come in helping, identify what are some of the barriers, what could be improved, and also looking at some of that other information to say, is there variation in our services? Are there particular populations we're not meeting, and so on? So part of this feeds into, so if we can go to the next slide, please, what Pam has also alluded to earlier is actually a cycle for continuous improvement. So to pull some of these ideas together, if we can think of our practice and the use of outcome measures and other data and information through a lens of this kind of cycle for improvement, what we typically think of probably as our kind of clinical practice is the doing of the doing. So particularly this planning and executing part of the cycle. But I guess hopefully what we've seen this morning is that actually these review and identify stages are equally important. And that's kind of where outcome measures can sit in this broader picture. So using outcome measures and other data to really understand the impact of your doing, and then using this and other information, such as the health inequality self-audit tool, to really identify potential things to change or improve, or things to develop within your service. So we need to keep on repeating these kinds of activities. And I think that kind of draws on the point that Pam sort of left off. Let's continue to evaluate, to monitor, to identify and change our services to ensure that we are always improving our quality to services, and to ensure the needs of our service users are fully and truly met. So I think I'm just going to hand back over to Kamini to finish off.
Thanks so much. So going back to one of the things that Pam talked about, which is who needs to know, and of course it's everyone really. It's as she's already had said, service users, families, staff members who've been delivering care, managers and leaders that you're accountable to as those who fund the service. So the final slide is just before I hand over to Vicky Stiles from me, is just that summary of remembering what we're here for, understanding your community and the individuals you're supporting, making sure you triangulate the evidence of what's meaningful for your service users to co-produce care pathways, and evaluate and improve as part of that continuous cycle, as Katie mentioned, and feeding back to everyone as to how things are going. So I'm going to hand over now to Vicky Stiles. So Vicky Stiles is a clinical manager at AAC West, and she's presenting on practical uses of outcome measure data, myth busting and maximising impact. Over to you, Vicky.
Thanks, Kamini. It's a very grand title, but I guess why I've been invited here to speak is that I've been working on outcome measures as a speech and language therapist, as a clinical manager for a department, and working on a national level for the specialism I work in for over 10 years. And I guess what I'm trying to do is consolidate those 10 years of work into a 15-minute presentation to give you a real-life context of all of the kind of theoretical information that's gone in ahead of me in the previous two presentations. I want to just quickly try and share my experiences and just show you the journey that I've been on along with my colleagues in my national working party, and share the lessons that we've learnt, and hopefully show you that it is possible to use outcome measures not only at a patient level but at a national level as well. So I work in a field called augmented and alternative communication. So for those of you who aren't familiar with that term, it's about providing high-tech communication aids to people who present with highly complex medical presentations and severe speech and language and communication difficulties. There's 14 services across the country that are commissioned to do this work, this specialised assessment work, and we were commissioned back in 2013, so we've been going for just under 10 years as a national group. But back in 2012, Communication Matters, which is the charity that supports the use of AAC nationally, commissioned a project looking at how we could use outcome measures and what would be the most appropriate outcome measures. So back in 2012, I worked with Pam in a working party, and we looked at all of the possible outcome measures that were available, and we decided the best fit for our specialism would be TOMS. So my presentation is very much about TOMS, but the principles that we're looking at, the principles I'm describing, could apply to many different outcome tools that your departments or you as clinicians may be choosing to use. So as a national working party, we were set up by our AAC advisory group, which is commissioned by the CRG, to very much look at how we could standardise the use of outcome measurement throughout those 14 services. So it's very grassroots. We're looking at what we can do ourselves as clinicians to provide information to commissioners about how we can show evidence the good work that we're doing in AAC. And we had 3 aims as a national working party: to agree how we can consistently use the tool, to explore the possibilities of a mutual database that we can pull all of the data that we're gaining from our outcome measurements, and thinking about our national working party being a national lead for answering questions around how TOMS can be used. Next slide, please, Catherine. So we thought it was going to be a super easy, quick working party, task and finish group, just about how we were going to embed TOMS nationally and make sure we all were singing from the same hymn sheet. Hasn't quite worked as smoothly as that, and I think it would be really useful for me just to spend a few minutes talking about some of the things that we've gone through, just because it might help in your context as well. So I think one of the biggest things that we found as to be a hurdle initially when we were trying to get the 14 services working consistently was thinking about, when do we actually do our TOMS? When should we be doing our initial TOMS? When is our first point of contact? When do we first want to do that score? And like many of us, trying to decide when we've finished a piece of work is really difficult. So when should we be completing that final TOMS? So defining when we were doing our data collection was a really big topic of conversation. And between those 14 services, although we're all nationally commissioned to the same service specification, it was really interesting the different pathways that have been interpreted by the 14 different services. So finding a standardised way of embedding TOMS consistently throughout the 14 services was quite tricky from that perspective. Also defining the descriptors that we were using. So the TOMS manual is fantastic with lots of different descriptors of how you can rate the work that you're doing and the clients that you're working with. And we were finding that different services were using different rating scales for different client groups that they were working with. And actually that didn't help us with our consistency. So we made a decision collectively that we would all work to the dysarthria scale, because fundamentally if somebody is a communication aid, they've got a speech difficulty, which means that that needs to be augmented or supplemented, or some alternative method used because of those speech difficulties. So that was one thing that we also had to define as a group as well. And once we did that, that really helped with that consistency, and the inter-rater kind of testings that we were doing became more consistent. We've also, as a group, collectively worked really hard alongside Pam. We wanted modifications to the tool for our AAC purposes, and Pam's been amazing and she's worked really well with us, and we have had those modifications added. So I guess that's a learning outcome as well. If the tool isn't right, talk to Pam, talk to your teams, talk to other professionals, see if there's better ways of using it, and work with Pam and make sure that they're going to be consistent. So the sorts of things we've done from the very first edition of the AAC descriptors, we've simplified it, and we've changed the layout so that we're not overcomplicating it. So we've removed some of the descriptors that weren't so relevant. We've added a support domain. So for us as clinicians in AAC, we highly recognise that it's not all about the person, it's also about the team that they have around them. And if that team isn't supportive, that can have a huge impact on the work that we're doing. So we needed that reflected in our TOMS data collection. And we also worked really hard at improving that support that that patient's getting. So it's really important for us as AAC clinicians that that was reflected. And also Pam alluded to this in her presentation. We're very much working now into a system with care aims in our data collection of TOMS. So we're thinking at the outset of each episode of care, what is our aim of this session when we're trying to do a new piece of AAC work? Are we trying to improve somebody's skills, which the majority of our cases fall into? But we've been going just under 10 years now as national services, and we know that communication aids only last around 5 to 6 years. So our re-referral rates are going up and up and up and up. And actually, somebody who is a really good AAC user, they know their hardware, they know their software, they know their vocabularies, actually the scope for increasing that person's activity and participation is going to reduce through no fault of the effectiveness of the assessments and the care that we're giving our patients. So we've actually now separated out into all of our patients who we completed TOMS on, into those who we're expecting to improve and those who we're just trying to maintain their skills because we're giving them a new piece of equipment, a replacement piece of equipment. And so we can separate those out in our data, which is really, really helpful. Next slide, please. Back in the early days, we had a lot of discussions around how can we pool our data nationally and how can we be consistent when we're collecting data in really different ways. So some services were very much using paper notes, some people were using kind of bespoke spreadsheets to collect their TOMS data, others were using electronic patient records where things were quite standardized, and some of us were using Root, the Royal College of Speech and Language Therapists online outcomes tool to upload their data to. But what we concluded was it really doesn't matter. As long as we're being consistent and we've got all of those foundations in place to make sure that we're comparing with apples and apples and pears with pears, our systems are aligned with one another, the format in which we're collecting our data really doesn't matter. So that was something that we had to iron out as a team. There are advantages and disadvantages to all of these, but in terms of data collection, in terms of TOMS, it's not an issue. Next slide, please. So those are some of the challenges that we had to iron out in the early days. Like I say, it really is a snapshot and a whistle-stop tour of the sorts of problems and challenges we encountered. But I thought it would be really useful to go on and talk about, as Pam has said, the ways that we can use our data and how we communicate the data to the people that we're working with. So first and foremost, the most important one is around patient level data. So we do a TOMS, as I say, at the beginning of our episode of care and at the beginning of our episodes of, and at the end of our episodes of care. And obviously what we're looking for is a change to show that the input that we're giving is making a difference for the patients that we're working with. So this is just a snapshot. This happens to be from a patient who had a diagnosis of motor neurone disease. So the purpose of AAC is we're not trying to change our impairment domains. We're not working at an impairment level, but through our work that we're doing, we're hoping to change the activity and participation. The introduction of a communication aid should assist somebody to be more active, communicatively active in the world around them and participating more in the world around them. So that's our ultimate goal. And so what you can see is this is a chart that we've pulled off of Root and that we can discuss with our patients to show this is where you started, this is how we jointly rated you at the beginning, and this is where you've ended up as a result of the introduction of a communication aid. And that's really powerful. For some people, like Pam says, it can be difficult for them to notice change in themselves, especially with a diagnosis such as MND. But this is a really visual way to show that things are improving. So we use our TOMS data at patient level data. Next slide. But as a manager of a service, I'm also looking at data from a service level, a service perspective. So again, this is a different report that I've pulled from Root. So this is something that I can do as a manager, that I can benchmark what my service is doing against the national average. So of the other 14 services that are using Tom's data and using Root. So looking at this data, I can see at a glance that actually the patterns aren't dissimilar from the top line to the bottom line, that there's a theme there that we're running parallel with other services. I think maybe that the last slide, the carer wellbeing, that might be something that we want to deep dive a little bit more into, because maybe our outcomes aren't quite the same there. Other services nationally are getting more in the green, so that is something as a clinical lead that I might want to go and explore a little bit more. But this gives me confidence that actually what we're doing is akin to what's happening in other services nationally. Sorry, I'm rattling through. So we could do this in terms of, we could look at data in terms of age, we could look at data in terms of diagnoses, we could look at data in terms of impairment levels, and just compare ourselves to other services. Another example of a service level data piece of work that we've done is we've gone through and looked at our episodes of care that didn't match up to what our expectations were. So we didn't get the outcomes that we were anticipating. So we did this piece of work for a Communication Matters conference, and actually the themes that were coming out were pretty consistent. And I know it's really small writing and you won't be able to see that in detail, but the two major chunks there were that COVID had a massive impact on our outcomes and were stopping people achieving what we had anticipated them to achieve. And also, as I've previously mentioned, support was another huge area that was impacting on our ability to achieve what we wanted to achieve. So as a result, as a service, we created a lot of online resources to try and give people more information about modelling, about scaffolding, about how to be a good communication partner. And so we're hoping to redo this piece of work to see whether those video online resources are helping with that support domain and increasing the support that people are getting. But we've also used our data for other issues. We've looked at, we've done an audit at a service level to see how our outcomes are with adults with a diagnosis of CP, and we've really deep dived into that to see what our outcomes and to see if we're doing all that we can. We have been looking at whether our outcomes are as high when local therapists, because we're a regional service, when local therapists attend and when they don't attend, to see whether there's differences there, to see whether we should be insisting that those local therapists support our appointments. We've also looked at sensory impairment and really deep dived into that to see how that impacts upon the work that we're doing. And as a result, it came up that the team didn't feel so confident with our clients with cerebral palsy with significant cortical visual impairments. So as a manager of a service, I've been able to go away and get the team training in that. So there's lots of evidence, there's lots of examples out there of how we've been practically using TOMS to help our service evolve and to make changes to give our patients as high a level of service as we can. Next slide, please. And as I've alluded to already, we're also using this data at a commissioner level. So we have very much been co-working with our national commissioner to think about what data do they want, what do they want to see from the work that we're doing, and what evidence do they need. So at the moment, we're just providing them with minimum data sets, and we know that that isn't the whole story. Timings, how long waiting lists are, how long it is till somebody gets a communication aid. For us as clinicians, although it's really important, isn't the be all and end all. We want to know that we've made a difference to that person's activity and participation. So we've co-produced with our commissioner a national data chart that all 14 services are able to submit on a quarterly basis. It looks at two different areas. It looks at compliance, so we need to know that everybody is reporting on 100% of the work that they're doing, so they're not picking and choosing the episodes that they report. And we're also looking at what the outcomes were for both our improve categories and our sustain, our management categories, and an overall, how are we doing average as well. So I think that's a really big step for us, that we're now in a position to start reporting that data nationally. Next slide, please. So as I say, that's a really whiz-stop talk, and I feel like I've talked at 100 miles an hour, but I hope it gives you a context of what we've been doing. Like I say, we thought it would be a start and finish kind of task group, but many years later we're still going, and there's a lot more that we want to do. So we want some of the plans that we've got as a national working party are to see if we can use the data that we're collecting from TOMS to help inform our triaging process. And that would help make sure that we're triaging as effectively as possible, as we've already talked about. TOMS for us as a service is one side of the coin. We very much want to standardise our PROMs and our PREMs as well, so those patient reported outcomes and experiences, because that will also help us improve the services that we're giving. Health inequalities, we're also working with RCSLT at the moment on a pilot project looking at health inequalities. So we're looking at languages, ethnicity and social deprivation using our TOMS data to see that we're providing consistent services to everybody who comes through our assessment centres. And we're also really excited. For the first time, we've got this huge amount of data, and I think universities are very interested in the data that we've been collected. So it's not only providing a practical, our TOMS data is not only providing practical information for us to change, but researchers are wanting to work with us and use that data from a research perspective as well, which is super exciting. And then the last slide for me, just again, a really quick conclusion on the lessons that I wanted to share. Some of the fundamental things that I think we've already touched upon. It's really important that you have regular meetings to make sure that that consistency is in place, that you're regularly sharing your TOMS data with your team. They spend a lot of time inputting this data, and so they need something back to keep their motivations high to keep on inputting that data. So we have regular slots in our clinical meeting where we focus on our TOMS data. And part of those regular slots as well is making sure that as a team, as a multidisciplinary team made up of speech and language therapists, OTs, teachers, etc., that we're standardising the work that we're doing. So there's a level of reliability, and we do lots of checking around that. But overriding lessons, I guess it's keep it simple. We have such grand plans in the outset of this working party of what we wanted to do, but we've really had to rein it in and keep it back and make sure that the basics are there so that we're all doing the same thing. There were huge concerns at the outset around the 14 services, around data sharing, and will be compared, and that's not good. Actually, everybody in the working party and nationally have found this a really positive experience, and those fears haven't come to fruition. It's actually been a really positive experience and a learning experience, and it has enabled us as services to make real life changes in how we're practicing as clinicians. It's really important, as I've mentioned, that we're all talking the same language, and we've invested a lot of time nationally and within my own department making sure that we're all doing the same thing in a consistent way. And I guess I just wanted to say this hasn't been easy. It's been a real headache, and we've had to really persevere with it, but I'm really proud of where we've got as a national set of services, and we've got a data set now that we're really proud of, and we know that it's showing what it says on the tin. So for us, we've had a really positive experience of using outcome measures in my clinical discipline. Thank you.